Today we have two wonderful speakers, Dr. Marianne Aznar. If you were with us last year, you probably remember her, as well as Dr. Udunna Anazodo. So today we're gonna have two sessions for our seminar, and it's gonna be about fairness and biases in medical AI, a very important topic that's not spoken as enough. So that's what we're talking about it today. So I see it's 10:32. I have made everyone co-host. So please go ahead and start, continue admitting people as you see them coming in. I'm going to start our usual introduction, and then I'm going to introduce our speakers. Are you able to see my slides? Great. Hold on. All right, as I mentioned, today we have two wonderful speakers. Marianne is going to talk about big data in radiotherapy, promises, challenges, and biases. And secondly, we have Udunna talking about fairness and biases in medical AI. First of all, land acknowledgement. If you do not know which land you reside on, please go ahead and follow that link. Our virtual event is based in Montreal, Quebec, which is the traditional territory of Kanakahaka and Zhang land, which has long served as a site of meeting and exchange amongst indigenous peoples, including the Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse indigenous peoples whose presence marks the territory on which peoples of the world now gather. We encourage you to learn and discuss about the history of the land on which you reside. And as usual, our admin, Victor Dumitro, might send you emails for communication from info@mecmedhacks.com. Prior to the session as a reminder, and after the session as a conclusion email, which includes all the information that you need. Please respect your fellow participants and use your real name on Zoom. And please mute yourself during the presentations. And I know sometimes it could be accidents, but just be mindful. If you accidentally unmuted yourself, please do mute yourself afterwards. Please go ahead and ask questions of our speakers on the Zoom chat. We'll monitor the Q&A session after each speaker. And then we'll have a little bit of a panel discussion among everyone at the end. So this is our timeline right now. Believe it or not, we're in the middle of it. We're at the beginning of week 4 now. Tomorrow will be the workshop of introducing the PyTorch, the deep learning framework has already been introduced. And tomorrow we'll have Dr. Mohibian talking to us about model training and evaluation. So we'll see you there. And just a sense of where we are in the timeline. Today, we're at the seminars, which is July 2nd, Saturday, with the 2 talks. And tomorrow, we'll have the deep learning framework model training and evaluation. And on Wednesday, we'll also have Dr. Mohibian talking to us more about PyTorch implementing your first own image classifier. And as a reminder for the program structure, today we have the seminar, and then we have the workshop. Hussein will let us know about this week's tutorial information, and will always be available on Discord to help. Just a reminder for the attendance, we have last year, if you're with us, we have programmed a Discord bot where you can ask the bot how many workshops have you attended, and which one are you still missing. If you didn't attend, you can fill the quiz, and I am going to launch this bot after the session and do a demo of it tomorrow, so that you can give the Discord McMedHacks 2022 bots a command, and it can tell you how much you have attended and which one you still need to fill the quiz for. So 70% of the workshop attendance and 50% of the seminar attendance is needed for the certificate. So, all right, we're now moving on to our first speaker of today, Dr. Marianne Aznar. We're very, very happy to have her again this year. Dr. Marianne Aznar is an associate professor in radiotherapy physics at the University of Manchester and at the Christie NHS Foundation Trust, the largest radiotherapy clinic in Europe. She is also a fully accredited clinical medical physics expert, having practiced for 7 years in Canada, also graduated from McGill, and in Denmark before moving to the UK and full-time academia. Her research focuses on delayed effects of cancer treatment, especially for patient groups who can expect a long life after their original cancer treatments. Diagnosis include Hodgkin lymphoma, breast cancer, and childhood cancer. She's actively involved in ESTRO, European Society of Radiotherapy and Oncology, and as a teacher and a member of the physics committee. She is also a physics editor for Radiotherapy and Oncology, which is the Green Journal. Thank you so much, Marianne. It's great to see you again after ESTRO this year. So please go ahead and start sharing your screen.
Thank you, Eugene. Thank you for inviting me again this year and for the wonderful introduction. It's really a pleasure to be here again. So hoping that you can see my slide and that you can see them in the right format. If not, please do let me know. I'm here today to talk about big data in radiotherapy, promises, challenges, and biases, which is really a way of saying, as a researcher that works a lot with large patients data set, how do I think and what have I learned about the potential challenges and biases we find in those large patient cohort? A bit of a disclaimer to start with. I think EDI is very important. I can't claim to be an EDI expert. I'm just learning on the job, as I said, as someone like many of you who often comes in the mathematical technical part between the patient data and the outcome data and trying to improve treatment and not necessarily being involved in seeing patients firsthand or collecting their outcome data. So I can claim to be an expert, but I think it's very important in this field that not only experts think of EDI and how we all take this as a responsibility to look slightly critically at the data set we work with and how generalizable they are to our patient population. I also wanted to give you a little bit of a background on myself. So as Eugene mentioned, I am a McGill graduate. That's why it feels so special for me to be here giving this talk virtually for my alma mater. I am French originally, but I came to Canada to do my master's. You can see this photo was taken during my first year's master in medical radiation physics at McGill. I went then to do my physics residency in Toronto, and I did my PhD in Denmark, where I worked as a medical physicist. I gradually shifted more and more towards research, and right now I'm a fully academic physicist, even though I like to stay very close to the clinical issues and to the patient. So I hope I fit within that translational space where my research is directly implementable in the clinic. So in this talk, I wanted to reflect a little bit on what we call big data. I know this is not a big data course, this is a machine learning and deep learning course, but we have to work with those large data sets. And I think it's important to know where they come from and how they've been built. I want to talk a little bit about selection bias in those data sets and uncertainties in outcome evaluation. I spent 2 years in an epidemiology department in Oxford, just I was doing my academic and research training. And I think this has really changed the way I think about these data sets. And I'm trying to spread the message to other physicists, as I think it's our responsibility to become involved in those things as well. So first, a little bit of reflection on big data and data mining. You've heard of big data, it's quite a buzzword. In radiotherapy context, actually what we call big data is not really big. If you see, anything that's big data in the space of consumer science, or Amazon trying to predict which kinds of products you would like to buy, they're talking about millions and millions of subjects. In radiotherapy, when we say big data, we often talk about cohorts of thousands of patients, and sometimes if it's a rare diagnosis or a small patient group, we often think about hundreds. That's still large for us because, fortunately, cancer is not a disease that everyone gets. But where we tend to think that the data is big anyway, it's more considering the depth compared to other medical disciplines or even other oncological disciplines. So we have all these images. We have a 3D dose distribution with lots of voxels. We have the onboard imaging that's taken every day that can lead to 50 3D images per patient. So this is where really the big is coming from. And this fits the definition of big data that probably a lot of you know, whether it depends on the version, whether it has 5 or 4 V's. There's the volume, there's the velocity, the variety, the veracity, and the value. And I think for us, there's volume in the sense that we have gigabytes of data per patient. There's velocity in terms of those images, and this data is being accumulated daily, etc., etc. So we still fit within the definition, I think, but it's important to realize where we fit compared to other disciplines. My main interest is the late effect of radiation therapy, and late effects are often rare. They occur in patients that survive a long time after their cancer diagnosis, and they can be quite dramatic, but fortunately quite rare events. I wanted to show this paper because this was never called big data, but I think this is a typical example of a large patient cohort where we try to infer the link between the dose distribution and an outcome that occurred 10, 20, 30 years after the original cancer plan. So if you're working in a radiotherapy clinic, and especially if you've been involved in breast radiotherapy, as you see here, you're probably aware of this paper. This has really been a clinic practice changing paper from Sarah Darby and her group at the University of Oxford, where they showed that in a case control study of over 2,000 women treated in the 60s, 70s, and 80s, that the dose to the heart was linked to a risk of major coronary events, so a risk of really considerable heart disease. It started 5 years after radiotherapy, but it was present even up to 30, 40 years after radiotherapy. They could see that some patients developed heart disease due to the dose received on the heart. So this is kind of a big data study, except that they, because it was already very complicated to accumulate the data from the 2,000 women, and because they were treated such a long time ago, it's a very common problem in late effects research. If you wait for late effects to develop, you have to go back to treatment practices that are slightly outdated. So they didn't have these nice individual dose distribution for all patients, right? Radiotherapy was planned in 2D on paper with standard fields for every patient. So the kind of work they did to infer the dose to the heart in this patient cohort is that they reconstructed the dose on a single representative patient. So they took a CT scan of what they considered to be an averagely built breast cancer patient, and they say, okay, those were the typical fields of radiotherapy used at the time, and try to reconstruct everybody's individual dose like this. Of course, as you can imagine, this has a large amount of uncertainty. You can never recover the patient's individual anatomy. Women don't come in this single size. The position of the heart within the thoracic cage is very different from woman to woman. So this paper has been practice changing because even with all those uncertainties, they could find a very clear correlation between the estimated mean dose to the heart and the risk of cardiac event. And I think in the clinic, we've been actively trying to reduce the dose to the heart in breast cancer patients on the basis of this paper. But I think there's been a lot of awareness also in the radiotherapy community that we cannot only rely on reconstructed dose for this kind of analysis, and somehow we need to use those modern radiotherapy data with the individual dose distribution received by any patient to dig a little bit deeper into this link between precise exposure, precise dose to certain structures, and the risk of late effects. And this is where I think these big data aspects come in. So what do we have in modern radiotherapy? Well, for each patient, you have the diagnostic tests that can be CT, MR, PET-CT. You have information about the prescription. And here I don't only mean the radiotherapy prescription, but you often have electronic patient records where you know if they've had surgery and what kind of surgery, if they've had chemotherapy and what kind of chemotherapy and how frequently. We, of course, have the radiotherapy planning data, as I mentioned, in 3D, along with, hopefully, all these onboard images, ideally in 3D, that can enable you to infer not only the planned dose, but the delivered dose to each patient's individual anatomy. We also have all the follow-up tests. Now, that depends a little bit on your healthcare setting, whether those follow-up tests are done in another hospital or if you're in radiotherapy center. But with, depending on your infrastructure, you might have access to all the follow-up CT scans, for example, to check for tumor recurrences, and you can learn from them also about the effects of radiotherapy on these patients. More and more hospitals are also implementing what they call patient-reported outcomes. So these are a set of questionnaires that the patients can fill on a regular basis, asking about, their symptoms, how they feel, whether they have some physical symptoms that need, for example, some further consideration, whether they need to be referred to a specialist for some issues that have been caused by their radiotherapy, their surgery, or their chemotherapy. So all of this creates a massive amount of data per patient that is extremely rich and full of potential, but it's also quite complex to analyze because it's multidimensional, it takes a lot of cleaning, and it takes some kind of novel methodology to be able to link it all together. As Eugene mentioned, the Christie is one of the largest radiotherapy clinics in Europe. Now, I know a lot of clinics claim to be the largest in whatever, and it depends how you count. But there's no doubt that it is a big center. We serve a population of 3.2 million people. We have a large number of LINACs. We also have some of the new toys like MR Linacs and protons, and maybe something that will speak to some of you. We have over 200 medical physics staff. That's not just for radiotherapy, that also includes radiology, but this is just to show you that this is a big clinic. So in a way, we thought that's one of the ways to take the advantage of these very large center is also to exploit the large amount of data that are gathered within this hospital. This is my colleague Gareth Price, and he's put 2 or 3 years of work enabling big data research for the rest of us. This is a very, very busy slide. The idea is just to tell you it's actually very complex to gather and collect all these patient data, even within the same institution. And I'm talking, everybody in our center, they get the surgery, they get the chemo, they get a follow-up within our own institution. But even then, if you want to do research on these data, you have to aggregate these data. The clinical data, the imaging data might be stored in slightly different databases. We need to link them and anonymize them and somehow copy them on a research database, which we call UKCAT. And that enables us to do some modeling without seeing the private patient information. So I just wanted to show you this, just so that you don't think that big data research comes out of nowhere. It takes a lot of infrastructure and it takes a lot of time, and that's not something. I think it's something that's too rarely mentioned and also too rarely appreciated, that it takes a lot of work for some people before you can start doing the fun stuff, which is the research, and before the first papers can be published. But once you have aggregated this data, once you have cleaned it, anonymized it, you're still left with the problem of how to analyze it. As I mentioned, these are multi-dimensional data. It's a very, very large amount. Very often, but not always, this data is going to be gathered and collected retrospectively. So you might put together some databases where patient outcomes are mentioned, but they've not necessarily been done or collected for the purpose of research. So there might be some standardization issues. And this is often what we refer to as data mining, as opposed to data farming, where something has been done with research and with analysis in mind. The definitions, honestly, they blur and they merge a little bit. There's not a clear difference between data mining and data farming. But as a rule, we tend to talk about data mining when we do things retrospectively, when we use real world data, so data from clinical routine practice, as opposed to data that has been collected specifically for the purpose of research. And that comes with some additional issues that I'm going to mention later on. At the University of Manchester, we developed a way of analyzing those large cohorts, which we called image-based data mining. Some other groups have done similar approaches and call them voxel-based analysis. So you might have heard both terms in the literature. But what we do is that we take each patient's individual CT and dose. And here I'm giving you an example of my own research, which is on childhood cancers. You would take, all these different children, their dose distribution, and then you merge all these individual CT dose on a reference anatomy. And that enables you to then collect all the deformed dose distribution on this reference anatomy. So you're trying to morph everything onto a template. And then you divide, in the simplest form of the methodology, you divide the patient cohorts into the ones who experienced an outcome, the ones who didn't experience an outcome, and you look, where are the differences in dose distribution that could explain this difference in outcome? And what you end up with is a group of voxel, or kind of sensitive subregion, that is correlated with a particular outcome. You can feed any outcome into this kind of analysis. As I mentioned, you can feed something binary. Do they experience an outcome? Yes, no. So, in the example of breast cancer, that could be, have they experienced any kind of heart disease? Yes, no. We also have developed some slight variations of this methodology where you can put a continuous outcome. So here, for example, if you're dealing with cognitive impairment, you could put an IQ test or any kind of cognitive function test where you get a score. And then you can try to see, okay, how many points of difference in this score correlate with irradiation of a specific region in the brain. So we think it's a very powerful analytical tool, because it's not based on contouring. And we all know that, contouring can be subject to inter-observer variation. The issue with contouring and defining structures also in toxicity research is that you have to kind of make an assumption that the effect comes from a particular region. And this type of analysis, where you look at the whole image and a whole group of voxel, it removes this assumption. So you come at it in a very naive way and say, we don't know where the toxicity comes from. Can we find some spots here, for example, in the brain that are associated with this toxicity? I want to show you a couple of examples, but really I'm going to go through these very quickly just to show you how this method works. This is the work from my colleague, Alan McWilliam. He took 1,000 non-small cell lung cancer patients treated with the same fraction. They formed everything to a template. So this would look something like this. You can see each one of this little flash of gray is a patient's individual dose distribution, and they're displayed on that reference anatomy. And then he divided the patient cohorts in those that were alive and those that were dead a year after treatment. And what he was searching is the pattern in dose distribution that correlated with the survival of these patients. You end up with something like this, the two groups and their accumulated dose distribution. And what Alan identified is that this overall survival was linked to, or at least was correlated to, a small region at the top of the heart here, just at the origin of the coronary arteries. And this was interesting because this is close to what they call the natural pacemaker of the heart, so the sinoatrial node, everything that electrically, makes your heart contract. So there was actually a good physiological explanation of why those there could be detrimental, could cause the patients to die of heart disease. But of course, anything in this research is highly, hypothesis generating, and we can only see correlations. We can definitely not find causation. So we had to repeat this analysis in different patient cohorts, and we now have other groups that have confirmed this in their own patient cohort. So this has been individually validated, that this region at the top of the heart and cardiac substructures in general, the dose to cardiac substructure does matter when you're looking at the cardiac health and overall survival of these patients. Now, why does this matter? Why did we find this so interesting as a result and so unexpected? First, there was this tradition that lung cancer patients didn't live long enough to experience cardiac detriment from their radiotherapy dose. And that's obviously been proven wrong. I think we've been very naive about how these patients who already have often bad heart health can cope with having their heart irradiated. It has also sparked a lot of interest in auto-segmenting cardiac substructures and going beyond the Darby paper, who looked at the mean dose to the heart, but really trying to find some specific correlations between dose to some small cardiac substructures and cardiac health. So that, again, has generated a lot of work. And if we had followed the traditional approaches of evaluating the dose to the heart and not following an image-based data mining or a voxel-based approach, we would never have found that small region because the signal would have been too washed out. Another example of why it matters not to make assumptions about where the toxicity comes from, you'll notice that this is a much smaller cohort, but still it was enough to give a signal. This is some work from my colleague Elena Vasquez-Osorio, and she looked at the risk between dysphagia, so swallowing issues that can cause the patient to to lose weight, and is an adverse prognostic factor. So she looked at the link between those swallowing issues and the risk of feeding tube insertions and dose deposition in the head and neck. And a lot of research has been done in this area, but has focused on the swallowing structures, the oral cavity, the masticatory muscle, the salivary glands. Those are structures that we can assume, we can hypothesize are linked to swallowing function because it makes sense. What Eliana found, though, is that there was another region that was linked to swallowing function, and that was the brainstem. And it makes a lot of sense because a lot of your facial nerves and a lot of the structures that are going to enable mastication have their root in the brainstem or run through the brainstem. But we would, again, never have found out this association by just looking at things that we thought made sense. So now that we have this first hint, we can rationalize it and say, oh, yes, actually, why, it would make sense that dose to the brainstem is correlated to swallowing function, but this had never been done before. This is unpublished work. This is still ongoing. This has not been validated in independent cohort or by other groups yet. So we still need to do a lot of work on this to confirm whether it's just a spurious statistical result or whether it is indeed a new finding. But this is just to show you the power of not making an assumption about where the toxicity comes from. I'm not going to talk a lot more about this methodology. I just wanted to give you a context of how we work with big data, but I'm giving you a couple of papers here if you're interested. And of course, feel free to contact me if you have any specific question. This is a machine learning course, so I thought I would have a single slide on machine learning. We do use machine learning in this process. We do some image registration driven by machine learning. We do some kind of photo segmentation issues, mostly to quantify the accuracy of our registration and not run the analysis itself. But this is the single and very quick machine learning slides. So at this stage of my presentation, what I want to say to you is we have tons of data and we have fancy modeling tools. So in a way, do we have everything we need? And this is where really the fairness and bias and EDI aspects come on. And this is where we think we have everything, but actually we might be biased by the data we do have. The first challenge that I want to mention is the biases in patient selection and encouraging you to look critically at your input data, so at your patient cohort. What is your patient cohort made of? And again, this is not something that I'm an expert on, but I'm giving you a couple of examples of our own experience in this IBDM work and of the literature that I pointed out. One of the things we know is that some patients are vastly underrepresented in clinical trials and in prospective research in general. This is a slide I took from my colleague Corinne Feverfin, where I don't know if you can see in this little graph here, there is a vast variation in terms of proportional representation, both in terms of ethnicity, with generally racialized group being less represented in clinical trials and in prognostic research. An overwhelming majority of the patients in prospective research are white, and they're also younger than your average patient population. So you might see these patients in clinical trials, or actually in clinical practice, doctors are treating these patients. And this is a big issue because it means a lot of comorbidities are not being accounted for in those clinical trials. So you don't know, for example, if you only accrue like healthy elderly patients, whether the fact that they have heart disease or they have diabetes could have an impact on your treatment effect or on your survival benefit. I would like you especially to see from this slide the discrepancy in terms of age, which I think is drastic. Look at this, age 75 plus or 65 plus compared to age 30 to 34. So one would be a proportional representation, so a just representation. You can see that the younger and fitter patients are vastly underrepresented in any type, overrepresented in any type of research. And it's not an issue that's only present in oncology, and it goes through a lot of underrepresented group, which I'm not, always an expert to talk about, and I'm definitely don't have the background of research to understand the scope of these issues. But just showing you a couple of examples from the literature, we know that minority and underserved population, so people from some ethnic minority group or even from some socioeconomic backgrounds, tend to not be offered participation in clinical trials, or might decline participation in clinical trials more for reasons that can be extremely varied. They don't have the time, they don't have the resources, they don't always have the best experience with the medical healthcare system, so they might be a little bit suspicious and not want to enter clinical trials. There is a clear need also in other fields. Here I'm giving you an example from cardiology of representing more elderly patients and women in clinical trials. If you've read some of the literature on the gender data gap, especially in cardiac health, you know that most of the clinical trials of heart disease are run in men, and we're just catching up with the fact that the signs of heart disease are slightly different in women, the symptoms are different, the treatments might not work in the same way. So all this experience that we've accrued from previous clinical trial is slightly biased by the type of patients that have been accrued in clinical trials, and we'll have to do a lot of work to catch up and to see what it means for those underrepresented groups. I wanted to give you one example that's specific to radiotherapy here, and this is a paper that's just in press, so I would encourage you to go and look it up if you're interested. This is just, it's not about representation, it's merely even about data collection. Like in all those clinical trials and prospective study, how many even collect data on ethnicity? And you can see that maybe in prostate cancer, it started earlier, but look at all those, in head and neck cancer, it's only very recent that we start collating data on ethnicity and what kind of patient group are actually included in those studies. So all the studies are claiming to do radiogenomics and claiming to look for the genetic link maybe to an oversensitivity to radiotherapy toxicity, but they're not collecting information that would enable you to say whether this data or whichever kind of genetic genomic link they find is actually representative of the patient population it's going to be used in. So there's a lot of catching up to do, and these are complex issue, and collecting ethnicity data in itself can be riddled with challenges as well. It's not only as clear cut as having several boxes and you tick a box, but I think there's an increased awareness of the fact that we need to collect more information and to ensure that whichever cohort of patients is included in this research is representative of the reality of the patient it's going to be applied into. So this is a bit about patient selection. The challenge that I may be most familiar with, and that might speak most to most of you, is the uncertainty in outcome evaluation. So this is looking critically at your output data or the data that you're trying to model. We know very well that side effects are underreported. They're underreported by doctors especially, they're underreported in some groups, but as a rule, if you ask the patients what kind of toxicity they experience, and if you ask the clinicians what kind of toxicity the patient experiences, you're going to end up with something that looks like this, with the patient reporting more toxicity than the clinician expresses. There's several reasons for that. There might be, rush time in consult. So the clinician maybe doesn't have time to ask all the questions. The patient is feeling a little bit intimidated. They don't bring it up, or they don't think it's serious enough. But there's also the problem of what it's called response shift, which is patients who are living with health problems and toxicity for their treatment tend to adapt to their condition and maybe not report it as much because it's part of their new reality. It's the new normal for them. And that you can probably understand from some subjective, effects like pain, but even severe and life-threatening effects are difficult to assess. And that might be very obvious for some of you who are of a, clinical background. I don't know how many clinical oncologists or doctors, like medical doctors we have on the call. But for me as a physicist, this is something that I didn't know. So for example, radiation pneumonitis is life-threatening. It's very serious. It's very, very hard to actually diagnose. Do you base it on images, a single image, longitudinal images? Like density changes can come from a lot of things. They can come from the effect of radiation. They can come from the fact that the patient has an infection, or they have COPD or other kind of lung conditions. It can come from some temporary effects. It can be fibrosis, which is an issue in itself, but is not pneumonitis. So images are difficult. And if you give it to different radiologists, they might not have the same answer of whether there is radiation pneumonitis in this image, yes or no. Do you base it on symptoms? These are subjectives. Where do you acquire the symptoms? Has the patient received any medication already by the time you do this assessment? So they had experienced toxicity, but it's been handled and addressed and taken care of. So if you're doing a project like this, you need to be aware of how your outcome data, your toxicity data has been collected. There's cultural effects if, for example, measuring pain. We know that patients in the US report less pain than patients in Europe. Why? We don't know. There might again be some cultural effects, or maybe the question is asked less. Even if you're dealing with recurrence and local control, that you would think that's a firm, really binary event. But whether the patient has a recurrence or not depends a lot on whether they actually followed up. They might have a recurrence and you don't know it. If you don't have a very systematic protocol to evaluate recurrence, there might be a lot of recurrences that you don't see. That the patient dies, yes or no, is slightly, more clear-cut maybe, but the cause of death itself is ridden with uncertainties. A lot of patients have, classified as dying with lung cancer. They don't know if they'd actually die from a heart disease caused by their lung cancer treatment. So all of this is complicated enough, but if you're using any kind of natural language processing or any kind of machine learning to retrieve those outcomes because you're doing this data mining and retrospective outcome evaluation, you'll see that you have a lot of issues also with even the fact that things are called differently. So this is an example, this is a real life example of my colleague Gareth, again, trying to look for esophagitis in a set of lung cancer data. You have spelling mistakes. You have the fact that esophagitis is called sometimes dysphagia. What does some mean? Is that a lot? Is that a little? Is that grade 2, grade 3? The patient is admitted with esophagitis. Does that mean that it's, how can you translate it into the grade? And what is difficulty swallowing? Can you translate this directly to esophagitis? So cleaning data and assessing those outcomes can be riddled with uncertainty and riddled with biases. If we go back to the issues of underrepresentation and representations of different groups, I find this paper from JAMA Oncology, again, it's a very recent paper, fascinating and somehow humbling. Here you can see a study on the side effects from breast radiotherapy, so skin toxicity and dermatitis. And this study really clearly showed that patients who were young or patients who were Black were not as likely to have their pain taken seriously and scored seriously. And if you look at the factors independently significantly associated with under-recognition, you also have a male physician sex and 2D field radiotherapy. So those things that, you can understand them when you see them, but again, it would encourage you to look at how your data has been collected, to be aware that you might not have the full picture of a toxicity event just because it's been claimed to be prospectively or even retrospectively collected. I want to show you one example it was very new to me. This was something that was presented at ESTRO, at the ESTRO Congress in May. And I purposefully didn't put references on this slide, and you'll understand why in a second. This is an example of the guidelines that is given to score skin erythema. So again, the kind of toxicity you would see in breast radiotherapy. Does anything shock you about these images? And there's only 2 here, but you can read the test as well. Erythema is pink coloration, mild edema. It's also mentioned as redness. And in this presentation that I listened at ESTRO, there was a much more thorough analysis of all the skincare and radiation dermatitis recommendation in the world. And all the images that you find are from white skin. There's very, very little information out there from nurses and clinicians to grade radiation dermatitis on darker or non-white skin. So the person who was presenting this at the ESTRO conference said that they were working on their guidelines. They were changing the words, you know, your skin can become pinker or darker, and they were trying to collect example of radiation dermatitis on a lot of different skin tones. But that just shows you that even the tools that we give to our healthcare professional are biased, and they're not adequate to the variety of different patient groups that are going to be used into. So what about your project? Now, I realized also that last year when I come and I talk about all these issues, you know, it's very complicated for you who are assigned a project. You have the toxicity data that you're given, you have the patient cohort that you're given, you're trying to do some machine learning modeling. What are you supposed about this? You have absolutely zero power to handle any of those biases. Well, I mean, the first one, the bias in patient selection, that's for you to keep in your mind and to think of when you become a PI and you design your own study. Think representation. Even with the data you have, it wouldn't hurt to go back and to dig into how representative the patient cohort that you've been given is to the variety of patients who are treated in your hospital. But for the outcome evaluation, I think there's definitely some things that you can do about being a little bit critical, and especially explaining and being transparent in your papers and in reporting your project about what data you've been given. And I'm giving you some examples from an editor's point of view of the kind of papers that I see and that I review. You might say something like this: we included 123 patients with lung cancer, and they had 50 of them had radiation pneumonitis. This is a terrible sentence. Don't say anything like this. This is nothing about your patient cohort. I need to know what kind of patients you included. Did you include this type of patients? Did you include this type of patient? So put a little bit about the performance status, what kind of the age that they had, what kind of other treatment they get, because that can give you a very clear answer about whether your analysis is on fit patient or slightly less fit patient. Also, don't say patients with lung cancer treated with radiotherapy. What kind of radiotherapy? Did they have SBRT to a really small tumor in a small field? Did they have locally advanced lung cancer and they got a really large field to a slightly different fractionation? So give those kind of example. I'm giving you an example of a better text here that you can go back, but this is necessary. And if you think your paper is very technical and you don't want to muddy the picture with all these kind of clinical information, put it in the supplementary materials for people to look at, but put it somewhere, because without it, nobody can tell whether your fantastic model is going to be useful to them at all. I would also recommend, and I know that this is very tempting to do if you want to increase the number of events that you have, but be aware of doing grade 0 versus any grade, because grade 1 really is no toxicity at all, and it may give you a more balanced data set, but really the editors and the reviewers hate when people do this. So consider at least doing it. When in doubt and when you don't know how much to report about your patient cohort, and again, be transparent about the biases that there might have been in the patient selection and in outcome evaluation, follow the tripod guidelines. They've not been made for radiotherapy, but I find them very, very useful as a checklist to remember. They also have a new version that's going to be out in a few weeks about machine learning specifically, and right to report both clinically and technically. So keep your eyes open for this. They even made a guideline, especially for abstracts, where you don't have a lot of words, you don't have a lot of characters, but you still need to give this information. So do check this. And you might remember this speaker from a couple of weeks ago. Check Anna Apple's tweet. She has fantastic tutorials where she reviews abstracts exactly with this kind of machine learning or statistical models. And she gives you some really, really cool examples about what not to do and what to do instead. So I find them very, very useful, and I highly recommend following them. So in conclusion, this is all about awareness. This is a bigger challenge that any one of us can solve individually within the context of one project. But I think it's very important, if you work with patient data and if you work with outcome data, that you are aware and that you acknowledge the biases and the possible weaknesses in your data set. This does not take away anything from your project, I promise you. It's only making it stronger that you're aware of these limitations. I would encourage you to talk to the clinical team and especially to the people who collect the outcome data that you're working with. It might not have to be a very long conversation, and it's not necessarily with a rad-onc, it might be with a nurse or anyone who's collecting this data, so that you understand how reliable it is and how subjective or not subjective it is. And with this, I'd like to thank you for your attention, and I'll happily take questions.
Thank you so much, Marianne. I really enjoyed that. So I especially enjoyed at the end you mentioned working with the patient data that you do have, what's in our control, and the even the new tripod paper that's about to come out. I'm definitely going to keep my eyes open for that. I think I originally said that we're going to start a Q&A question for your talk right now, but Dr. Anazodo actually would like to present now so that we can, I think she has a lot of valuable insights that can probably bridge from your presentation and keep moving forward and with her presentation. So she can go ahead now, and then we can do the Q&A question together. So
Brilliant. No worries.
yeah, okay. And would it be okay if I introduce you, Udunna?
Sure, go ahead.
Okay, yeah, all right. So thank you, Dr. Anazodo. It's my pleasure to introduce Dr. Udunna Anazodo. She's an assistant professor in the Department of Neurology and Neurosurgery and a member of Neuroimaging and Neuroinformatics, a research group at the Neuro at McGill University. She joins Neuro from the Lawson Health Research Institute in London, Ontario, where she was an assistant professor of medical biophysics. Udunna's research at the Neuro will focus on intelligent PET imaging for mapping brain health from molecules to mind. Her lab combines positron emission tomography PET and magnetic resonance imaging MRI techniques to provide a multimodal image approach for detecting subtle and early changes in brain function, physiology, and neurochemistry. Her current focus is on the optimization of next generation ultra high resolution PET imaging system to permit molecular brain imaging with unprecedented spatial precision and sensitivity. Yeah, so thank you so much, Udunna, for being here with us. And I look forward to your talk and the panel discussion alongside Dr. Aznar at the end afterwards.
Excellent. Thank you so much. Can you see my screen?
Yeah, go ahead.
Excellent. Let me just get my highlighter here. Excellent. So thank you so much for the invitation. I'm kind of really happy to follow Marianne. She did a great job introducing a lot of concepts that I figured she would do, so I didn't get to actually do that. And a lot of this talk will actually focus on my approach, what we're trying to do, at least in my group, to address the first challenge that Mariam talked about, which is the challenge in terms of bias in patient selection and how we're trying to sort of address that. It's going to be a different take on how we are, how I'm thinking about being able to plug in some of these gaps when it comes to being able to have inclusive medical imaging data. And you see that our approach kind of lies a little bit on capacity and policy, as well as infrastructural challenges to address those. So I think that when you ask anybody in the health field, including medical imaging or medical data, what they think about bias in AI, I think the Google goof, it's what kind of comes to mind. And I think this is good because this kind of allows us to take a step back and make sure that we're actually understanding the problem that we're trying to solve. I do like to sort of echo what Gilbert Chesterton said, who is a 19th century philosopher that said that it isn't that we can find a solution, it is that we can see the problem. And AI has been sort of touted as the tool that can enable a lot of in terms of medical care and in terms, especially when it comes to medical imaging, allow us to solve a lot of problems because computers see better than humans, and we do know that. But then when we don't have a data that can actually allow us to see the problem, then we're not able to find a solution. Marianne already talked a little bit about the need of why we need to sort of diversify medical imaging data. She talked about the fact that most clinical trials, what we know so far is actually from drug trials, and this is information from the FDA and the CDC as well, compiling this information together, which shows that a lot of the clinical trials that we do, both globally, in the US and then the rest of the world, tend to focus on a narrow population. That population tends to be Western, educated, industrialized, rich, democratic, what we call weird populations. I think when people think about weird, they think it's synonymous to white. That's not what it is. It is Western means everybody more likely in this room, who are also educated, who come from industrialized countries, who tend to have richer resources and live in democratic populations. So it's not down to ethnicity or race, it's actually down to the environment where you find yourself. And so what does this mean and why should we be concerned about making sure that our medical imaging data is non-weird? I think the answer to that is that if you look at where the non-communicable disease patterns are, where the incidence, where the death rates are, where the mortality morbidity is, it's not in this weird populations, it's in non-weird populations. So the non-Western, the non-industrialized, the non-educated, and also the non-democratic. A lot of African countries are semi-democratic or non-democratic. And so this is where the burden of non-communicable diseases are. I think what people tend to think about, and a lot of this talk is going to focus on Africa. I do apologize for that. I'm African by heritage, and also this is a continent that has the most challenge when it comes to AI, or when it comes to medical imaging, or when it comes to healthcare. So we're going to focus on this because if we can disentangle and solve the complex overlapping challenges that happen in Africa, we can solve it anywhere else. And if you also look at where the burden of diseases, it actually resides in this region. And why we focus on NCDs for two reasons. One, the World Health Organization, as well as several different epidemiology studies, have shown that there is an economic and demographic transition that's happening globally, where people are not only moving from rural to non-rural areas, where countries are getting more and more industrialized. And so there is this rise in non-communicable disease, cancer, stroke, Alzheimer's disease, traumatic brain injury, lung and respiratory diseases. So these are not non-infectious diseases. And I think typically when people look at Africa or tropical regions of the world, they tend to think that infectious disease is the main concern. That used to be the case. That's not the case anymore. That won't be the case in the next 5 years, where non-communicable disease, cancer, stroke and all that stuff is overtaken the death rates in these countries. Now, what do we have in terms of tools to look at cancer or Alzheimer's disease or neurological problems like epilepsy or stroke? We do this very well with imaging. An MRI is one of those imaging modalities that actually allows us to do a little bit more, that looks at both soft tissue information, functional information, molecular information, and it's a very versatile tool. When it comes to all the imaging toolkit that we have CT, we have positron emission tomography, for example, if you're looking at cancer. But MRI is, when it comes to being able to look at these disease patterns, MRI becomes a bit more versatile, but it's actually the most, one of the most available, relatively available tools. However, if you look at where the distribution of our scanners are, this is where obviously we have to start collecting data to be able to imaging data to be able to answer these questions. I mean, these non-communicable diseases are not stuff that you can do with just blood samples or clinical profile. You know, imaging becomes the bread and butter, and being able to understand, diagnose, treat, and look at the efficacy of treatment, all that stuff. So where are our imaging modalities, where our data acquisition tools are, they're not where the distribution, they're not where the disease is. And so if we're talking about being able to close bias in patient selection, we have to be able to close bias in where the data acquisition tools are. And this is what basically my lab is trying to do. And this is a lot of the focus on what I'm going to talk to you today about. we've sort of started to look at this because when it comes to medical imaging, and again, I'm going to focus on MRI for the reasons I mentioned earlier, we find that, and again, like, I'm going to butcher your name. Eugene, when she introduced me, mentioned I focus a lot on brain imaging. Brain is a little bit one of those interesting parts of the body. Again, in most conditions, CT is not typically that useful for brain imaging. So a lot of this, a lot of focus in my lab revolves around MRI and also positron emission tomography. But here we're trying to demonstrate why we need to diversify medical imaging data, which goes beyond just the fact that we're looking at this from a geographical or from a ethnic group. It's not because of the fact that these data sets are not in non-weird areas, like I mentioned, is the fact that in these parts of the world, the image quality is still a challenge because the technologies are either obsolete, like in 0.3 T Tesla. Obsolete means that these scanners are beyond their obsolescence period. So they are past their regular period of maintenance and not well maintained. So they do have a lot of variance and shift, which causes a lot of noise. They also are not, they're in countries or areas where protocols are not quite optimized. So the size of the images, the voxel of the images, or the spatial resolution, the contrast you have is really quite poor. And also this is parts of the world where contrast becomes a bit of a challenge. So this is an example here showing a stroke patient from acquired here in London, Ontario on the 3 Tesla MRI scanner, and a stroke patient acquired in one of the hospitals in Nigeria on a 0.3 Tesla MRI system. And for those that do medical imaging, the higher the field strength, obviously the higher spatial resolution, as well as the faster you're able to image, and also the better your SNR is. Now, there's also a couple of things going on here. One is that here in the West, in Canada, our stroke protocols include both being able to do multi-parametric or multi-sequential. So we do diffusion-weighted imaging, we do contrast, non-contrast, we do SWE and all this other stuff. Well, A, they don't have the capacity to do that. B, you're talking about a scanner that services a large area of population, sometimes 5 or 6 times the number of patients that we see in a given clinic here in the West. You also have physicians that are subspecialized or actually non-subspecialized. They're seeing patients from ultrasound, so they're reading ultrasound, X-ray, MRI, CT, and they're reading from head to toe. So there is a big gap in terms of the error margins that some of these images can produce. So then the problem becomes multifaceted. Problem number one, we don't have a breadth of data, so we don't have our contrast, non-contrast, our DWI, our actual 3-dimensional T1, so that's a breadth. The quality of the data, as is shown here, becomes a problem. How you annotate the data becomes a problem because you don't have people that are able to annotate the data. So that becomes a huge problem. And this is obviously where that capacity, being able to figure out how to solve these problems come in. One thing we're trying to do in the lab is to use the power of AI, to leverage AI to solve the problem as is right now. Obviously, we cannot buy new scanners. We cannot, at this particular point, train neuroradiologists and have them subspecialized enough to just read MRIs like we do here in the West. But we can try to figure out how we can use maybe artificial intelligence to sort of see the problem and then figure out how to solve the problem. So one thing we're doing, this is a work by Dong Zhang in my lab, who is trying to figure out ways to understand the breadth problem. So that's that few shot. And the example I gave you earlier, where we have multiple shots, or plenty of shots, so we have different breadth of variety of data, but also have a lot of useful, good quality data. In typical countries like in Canada, in most of the low middle income countries where they have few shots, so they'll typically only have T1 and T2 weighted imaging. Most of the time they're not 3-dimensional. So for example, this data here, and we have lots of them, their in-plane voxel is about 8 millimeters. I mean, this is a 1 by 1 by 1. So this was a 4 by, so this was a 5 by 5 by 8, and this was a 1 by 1 by 1. So you have this few shot issue, and you also have the low quality problem. So how do we sort of try to create AI tools that are generalizable enough that we can segment stroke lesions or brain lesions or glioma lesions on these images and still have similar outcome or reasonably equal outcome? I think some of you here may be familiar with the BRATS challenge, so the brain tumor challenge, running now for almost 11 years, where they provide data and also ground truth information, and they give people the opportunity to design tools to segment these data sets, to classify the tumor. Now they're getting into prediction. We've tried to see if using this top performing BRATS challenge, architecture models, how are they able to handle MR images from these typical low quality few shot settings? And I'm just skip forward and skip back on some of these the top performing ones, including the ones that sort of kind of have started to think about these few shots, do not really perform very well in terms, the accuracy sometimes fall below 19%. And the dice coefficient is quite low. And that's because, like I said, sometimes we haven't really taken time to understand what the data can and how we can solve this problem. So we try to do is we try to create sort of a way to leverage what we know that AI can do, which is one thing that AI does very well, is to be able to learn a little bit based on what the data have, sometimes learning using attention mechanisms to look at things globally. And then progressively sort of refine it, which is what we're trying to do here in this SIME approach, where we're trying to identify, predict lesions on a larger, what we call plenty shot images. So what we did is we actually leveraged glioma data sets. So we leveraged the BRATS challenge data sets, as well as the ISLE, so the stroke lesion segmentation challenge that Mikhail run data set as well. And we use those data sets to simulate what looks like the type of data sets we get from the country, but also that actually allows us to also train, because the glioma data sets were way more than the stroke data sets, and we're trying to segment stroke lesions as well as glioma from this particular approach. And so we had this idea of being able to sort of pay a bit of attention of how we are learning features, because glioma and stroke kind of have similar features. They do have the same, what appears to be that penumbra, that region of high versus low enhancement in glioma, or the penumbra versus the core in stroke. Sometimes gliomas can be, gliomas can be sort of appear to be what they call stroke mimics. So they do have features that are very similar that we can actually try to learn from, and sort of use that to design a method or a tool that will allow us to actually go back and segment stroke lesions on images that have few shots. So we have few multispectral images, and we may sometimes even have few data sets. And that's actually what we did here. So this is an example from one of those simulated stroke lesion data sets. Again, they're simulated to have the same voxel size, image quality as images that we tend to see from Africa, from like low field strength systems. And we do have a ground truth, because the ground truth actually came from the ISLE challenge. Here we're showing segmentation using the top performing existing BRATS data, including BRATS models, including some that do have some amount of few shot or low shot information. This is one of those fine-tuned ResNet. And then this is our SIME approach. And you see, by actually paying attention, trying to understand what the features are and trying to learn a little bit better as to what the data we have can do, we're actually able to start to segment these lesions a lot better than some of these top performing tools. So this is how we're thinking about it in my group. And the reason we're thinking about this in my group is because we're a bit pragmatic as to approach. Obviously, we cannot solve all the problems. Like I said, we cannot start to change a lot of the infrastructure. The barriers, and when it comes to inclusive medical imaging and trying to make sure that these tools are generalizable, as to like what Marianne pointed out, challenges in patient selection and actual challenges in how to do outcome evaluation. We're trying to think about this in a systematic way, especially when you're talking about a continent like Africa, where there is no political will in terms of being able to provide healthcare. Health funding in the continent is typically less than 1% of the GDP, except for South Africa, which spends a little bit more than that, 3 to 4%, still way less than we spend in Canada or in Europe or in the US. So you have governments that don't invest at all in healthcare. When they do invest in healthcare, they tend to invest in healthcare that has to do with infectious disease, maternal or child care. So typically what we do with imaging, which is those cancer, Alzheimer's or stroke, all that stuff, they don't even tend to invest in that. And that kind of makes sense because these machines are our medical devices are really expensive to acquire and obviously expensive to maintain and run. But in order to make medical imaging inclusive and AI applications, and in terms of patient selection, you have to be able to figure out what are the barriers that sort of prevent you from getting the data that you need. And we've looked at these barriers across what we call 3 pillars. We do have a tutorial that sort of summarizes and captures this in Radiology AI, and I'll encourage you to read that. Like I said, we know that AI has a potential to improve healthcare, both on a global population level, more so in the low middle income countries, because the burden of disease is greater, and also they have that limited healthcare infrastructure, personnel, which I already talked about. So the barriers to being able to make medical imaging for AI applications more inclusive runs along infrastructure, personal capacity, and policy. And infrastructural is just the quality of the data, how we acquire the data, what systems do we have to acquire data, where are the scanners, what populations do these scanners actually cover, who can access this population, who can access the scanners, how do we archive and store the systems. When I was in Nigeria in January 2020, I visited a few medical imaging clinics. Somehow, in the waiting room, I saw people carrying this travel bag. And I was wondering why people are sitting in the waiting rooms with these travel bags. And I asked one of the radiographers or technologists while I was waiting to talk to the radiologist. And he said, oh, some of them travel like 3 or 4 states to come over. So they have to sleep here. We have to do the images, and then they have to take their CVs back with them. So, they don't even have a PACS access or storage. The referring physician is 2 or 3 states away. They have to take that CDs back. I was talking to a colleague that has a stroke clinic in a totally different state in Nigeria. And one of the issues he had was he's trying to figure out how to get PACS working, because his patients come to him at the stroke clinic with their MRI and CT scans. And they've had cases where patients show up with the wrong CD and scan. And so this is a stroke patient showing up with a travel bag, come into your clinic, and it's the wrong scan. You have to send the patient back. So they've wasted money, which they don't have to pay for transport. So something as simple as that is just one barrier to that particular data actually being available to help them for stroke diagnosis, which they desperately need. And obviously, one of the reasons why PACS is a big problem, or archive and search information is a big problem, is because of network connectivity issues. Computational power is a given, that's just straightforward. If you have power infrastructural issues, you will not be able to have that computational power that you have. Even being able to access cloud storage or cloud computing requires, it's expensive, and that's something that oftentimes becomes a barrier. Personnel, image acquisition analysis, the quality of your data depends almost entirely on the quality of the staff that's able to acquire, the personnel that's able to acquire the data, the quality of the radiologist that's able to protocol and set up the right and optimize these protocols on scanners that are now obsolete. Some of these scanners don't even exist in the West. Even their 1.5D systems are either refurbished, repurposed systems. They may have a Siemens, Philips, or GE front end, But the magnet itself, it's a recycled old system that has been put together by a third-party vendor. In Africa, there's very little vendor interaction, which means that when they buy the systems, they buy from a third-party distributor. And so they don't really have the same access to the same type of sequences that we do here. And even if they do, some of those sequences are not optimized. They sometimes don't even know how to optimize those sequences. So the quality of the data acquisition becomes a bit of a problem. And so there is that capacity gap in being able to even acquire good quality data. Data curation and annotation, that is also a place where they do require some amount of personnel skills. I think Marianne sort of pointed out to this in terms of outcome evaluation. If you're not able to provide them a way to annotate or even understand how to annotate the data, you don't have your outcome metrics out there to even use for your training. The informatics and computational skills, in terms of medical imaging and computational skills, that's a huge gap. There is a big, at least in Africa, there is a big ecosystem for AI, but a lot of the ecosystem is spent on fintech, financial tech, because there is success stories in terms of being able to start up entrepreneurships and stuff like that. When it comes to medical imaging or healthcare, I think the entrepreneurial aspect of it is kind of lost, so there's not that much interest. So being able to figure out how we can take some of those computational ecosystems, some of those computational capacity that we have in the region, and sort of funnel it into medical imaging and healthcare will be one way of being able to plug the gap in terms of that bias and access. In terms of that bias. And then data privacy and confidentiality. There is very little or no, when it comes to medical imaging data, governance structure in the region, or even in terms of privacy and confidentiality, how the data is used, data protection, that doesn't exist. What I mean by that is that here we have HIPAA compliance, we have the GDPR in Europe, we have the PG or whatever you call it here in Canada. This gives us a way of any institution that's doing medical imaging to figure out how to make sure that data is protected. So and de-identification, some of those policies and rules guidelines does not really exist in the region. There are work right now to figure out how to do that. Medical imaging compared to any other data set requires that added protection, because your DICOM information has patient identifiers sort of tied to it that has to be separated. And also, especially when it comes to head or brain imaging, you can actually have the person's face recreated from especially MRI or CTs or even PET. There's a paper that came out the other day showing that you can actually recreate a person's face from FDG PET imaging. So you have to also deface that, and that's something that we don't typically see with any other medical data. So you don't deface a lab result, or you don't deface a clinical report. So imaging requires an extra step. And again, having that privacy and confidential policies are completely missing in some of these regions, which actually then creates bias. Data governance it's also a big issue, because data is the new oil. I think you may have heard that. When I was in a bunch of clinics in Nigeria, this is not just unique to Nigeria, I could have literally walked out with those clinics with hundreds of data sets. I mean, I do have some data sets right now. So there's no governance as to how this data is being used. And in Africa, where 90% to 80% of the data comes from patients paying for the data by going to the clinic, because again, there's no universal health insurance. And these patients are paying out of pocket $200 for an MRI scan. That's equivalent to almost 80% of their monthly salary. So they are providing the data sets, and then somebody's going to walk in because they want to do breast or glioma AI to help them. I mean, we have to have a way of having governance where there's also benefit directly back to the community, because they're the ones actually paying out of pocket for this data set. So if we're going to use the data sets, we have to think a bit better as to how we use it in a way that's actually beneficial to them. And so being able to have a way of figuring out all of these infrastructure, personal capacity, and policy biases is what we're trying to do. We're trying to do this through two means. I mean, like I said, some of these infrastructural issues like the PAX storage access is what we're thinking about how to overcome. But with camera, which I'm going to talk to you a little bit about this network that I formed, and what we're initially now starting to do with this African Neuroimaging Archive is to try to address these two barriers. Most of these two barriers, again, like I said, we're working on this infrastructural PACS archiving system, and also being able to improve image acquisition. And image acquisition can be improved with AI, for example, in how we do MR reconstruction, denoising, and stuff like that. I want to take a step back, because when we talk about this, to me, I think this is the biggest one to tackle, because if we give people the power to use and to understand what they can do with their data, to get the capacity to create those tools, those AI tools, to solve their own unique data, because the problems is not something that we can see in the West. They do have unique healthcare challenges that we don't tend to have here. So some of these non-word populations, if we give them the power to be able to acquire good data, given their current infrastructural challenges, because they can do that, given them the power of experience to be able to annotate and then gain computational skills, they will be able to sort of knock down all of these other challenges. So we're focusing on that personal and capacity building. And I want to kind of use COVID to point out why this is good to focus on this. Now, if we look at what's happened in Africa in terms of COVID, I think there is still, this is up for debate, but there is still some evidence showing that they did have the lowest death rates, they did have the lowest infectious number of cases compared to any other part of the world. And it's a puzzle, but I think we're now trying to understand why Africa's had fared better. I mean, people tend to say, oh, we don't have good records of death rates. I think that that's not true, because if you looked at what happened in Ecuador or other parts of Latin America where people were dying, there were corpses in the road. We didn't see any of that in Africa. I mean, we saw that in Ebola, so we didn't see that in COVID. So we know it's not that they don't have good records of deaths. People are saying the younger population, but I don't think that's the case. I think what's happened in Africa is that they gained the power of experience on how to handle infectious disease. So over the past few years, the Center of Disease and Control, so CDC, there have been a series of that sort of popping up across Africa. First one was in 2011 in Nigeria. The Nigerian Center for Disease and Control was set up. And this was actually happened way before the Ebola epidemic happened. The African CDC at the same time took over a few years to set up this countrywide, or continent-wide, I should say, Center of Disease and Control. Both are modeled after the US Center of Disease and Control. So Nigeria sort of gained the experience of having trained experts in place. So people that are there on the ground, that work on the ground, that see the problems, understand the problems. They were actually there on the ground, and this is a quote from CDC, having these people in place was what made a difference when it came to Ebola, because Nigeria had one case, caught it at the airport, treated it. The patient survived, the doctor died. And that's because they had the power of experience. This was a publication in Nature, note the date, February 2019. That's a whole year before the COVID pandemic, where they declared that this doctor from Nigeria might be the next person to prevent the next deadly pandemic. And that reason they said that is because over the few years, like I mentioned, from 2011, the Nigerian government, the only thing they've actually done that's good, started to invest in being able to beef up the infrastructure as well as the capacity. That capacity is the key of the country to be able to handle any pandemic. And they were able to do that for Ebola. When Dr. Ihekwezu came to sort of direct the CDC, Nigerian CDC, he started to put molecular lab networks in the country. This is March 2020. So right at the beginning of the first wave of the pandemic, he already had this molecular labs in place, including the ones that could do, all of them doing PCR, including the ones that could do genomic testing. If you cycle through right towards December of 2020, he filled the country with these labs, meaning they were able to do surveillance really well, and even start to look at genome sequencing. This was not only happening in Nigeria, this was happening in Senegal, this was happening across Africa through the CDC, which is why we were able to discover what's called Omicron. So by having that power of experience, we not only did Africa benefit, we all benefited from knowing what Omicron is. And if you look at, what other pandemics might be going on, and I'd like to share this slide because I think oftentimes this kind of brings into perspective. This is the data from CDC showing the number of deaths in the US in 2018 compared to the COVID deaths over a 2-year period. So this COVID death is over 2020 to 2022. I think this was as of April of 2022 in the US. And this is the deaths of heart disease in 2018, cancer, 2018 Alzheimer's, COVID is number 3. That's combined of 2 years. This is just 1 year age. If you look at the age group that were the most vulnerable, you see that COVID is still number 2. Heart disease and dementia are actually the number 1 killers in this particular population, almost similar to cancer. Heart disease, Alzheimer's disease, and cancer are stuff that we do very well with imaging. So again, if we come back and say, let's look at Africa right now, what's the powerful experience when it comes to being able to handle this ongoing pandemics, stroke, cancer, dementia, stuff like that? What is the powerful experience in terms of imaging? Like I said, the infrastructure to do imaging is very expensive. But the purchase installation, this is a problem that requires a little bit more of a political and government investment. I mean, there are efforts now to create this portable low field systems that make them a little bit more expensive. But what we can do right now, each of you can do, is to start to figure out how you can help them gain that powerful experience when it comes to MRI, because when they have that experience, they're able to create the data that we need for AI. And this is what we're trying to do with camera. I formed this group in 2018 as a working group, initially under the European Study of Magnetic Resonance in Medicine and Biology, so ESMRB. But it's now a network, multidisciplinary. We have radiologists, physicists, computational engineers, biomedical engineers, engineers that are actually building MR scanners. We're trying to create this unbroken chain of resources and expertise. That's the unbroken chain of resources and expertise that we saw happen during COVID in Nigeria and across Africa, with this labs being set up and the expertise. We're trying to create that so that we can enable Africa to use MRI to realize their healthcare needs. And their healthcare needs, including being able to get that good quality data that will allow them to get a good use of the AI or make the AI models more generalizable. We have this framework, which I'm not going to spend too much time on. This is our approach. It's on preprint in medRxiv here. You can read about it. But what we're trying to do is we're trying to advocate, and that advocacy is actually what I'm here also doing. We're trying to create partners that will actually work with us in terms of being able to provide really good quality training. Training across everything from the way data is acquired to the radiographers, the way data is interpreted, annotated, and that evaluation, the radiologists, medical physicists that will actually help us use AI on computational imaging, people that will also use AI also to improve the diagnostic quality, improve their ability to read or even diagnose images. And we're trying to build a network across that unbroken chain across Africa that will actually help us to improve how we use the current infrastructure, how we enhance MRI practice, again, using AI as well. And, you know, when we do all this work, and when we advocacy also includes being able to actually get the governments to see the value of MRI and invest in it in terms of meeting the NCD healthcare needs. When we do advocacy training and networking, we then have that innovation. And I'm going to skip through this because we didn't just think up this protocol. We didn't just think up this concept from thin air. We actually spent 3 years doing really good need assessment surveys. Those include actual surveys that we had 157 responses across, that's 157 clinics across Africa help us with this survey. We also have a series of focus meetings that we run across international meetings to hear both voices from the continent and voices from outside who can understand the problem from the continent, so together we can create the solutions. The results of this is in the archive, like I mentioned, but what was really exciting to see was that there is really good interest in being able to do research. A lot of the research interest did mirror the clinical indications. A lot of the research interests actually focused on brain imaging. We did see how they want to train. So we did see that there is a gap in training in terms of personnel. So the radiologists and the radiographers had different modes. The radiographers, for example, were okay a little bit with online training, the radiologists not so much. We saw that a lot of them don't participate in international meetings, which is not good because we need that networking to happen. We need to be able to exchange ideas, and they also need to learn what we're doing from the West here. We were happy to see that there is an uptick in terms of being able to install this high field system, so 1.5T MRI systems. And that's because they have on their own figured out how to couple up power supply to be able to power the MRI and CT Linacs for 24 hours. So this is a picture for one of the clinics that I visited in Nigeria, where they are powering up both from the grid, their local grid, as well as solar and all the alternative diesel power. They're able to run a UPS system, and this clinic also has a good pack and IT person. And that's one thing that I forgot to mention, is that they actually don't have, a lot of them have no IT support. This is one of the clinics that do have that. And again, if we're able to start to take, for example, what they've done in terms of being able to manage the data, figure out how to sort of distribute that and give that type of a training experience to the rest of the clinics, we now can be able to plug in some of those gaps when it comes to being able to get inclusive MRI data sets. So I'm going to start pivoting towards ending here, because like I said, we all can work together to solve one of the barriers, which is that capacity barrier. We have some ongoing training initiatives through CAMRA that we're working on. It would be nice to have some of you MedHack trainees or trainers to sort of come and join us in being able to create this powerful experience to turn our African colleagues from users, because that's what we tend to think of them, give us data people, to actually experts and co-creators, to enable them to also create solutions that we can solve, just that they were able to detect Omicron, which we all benefited from. They're also able to create solutions for medical imaging and radiotherapy that we also can benefit from. We're creating a global network, and this is still in process. We're trying to link our African colleagues to both colleagues within the continent, because some of them do have, actually not some of them, they all have isolated expertise. So trying to link them together, as well as link them out with the West. This is where probably a lot of your attention will come on. So we just got this grant from Lacuna. We're trying to create this African neuroimaging archive that I mentioned about. This is not just to collect data and annotate and release them. What we're actually trying to do is a little bit beyond. We're trying to hit that barrier of policy, as well as a little bit of the infrastructure. What we're trying to do is trying to create a platform where we can archive brain MRI data sets across the continent, including from clinics that don't have access to PACS. So we're trying to create a delivery system where we actually enable them to contribute data to this platform, also enable them to have a governance as to how they want the data to be used, who gets to use the data. It is going to be open source, but it's going to be a little bit of policy that's going to be put in place in the absence of this government policies. So we're trying to do all this stuff. We're also trying to run a brain MRI hackathon next year, because we're trying to plug that gap in terms of the lack of capacity when it comes to medical imaging, computation, and informatics system. And one thing that we're going to try to do next year is we're going to try to take one of those brain MRI data sets, focus on glioma, annotate them, curate them, and release them as part of the 2023 BRATS Challenge. So that 2023 BRATS Challenge, we have African data sets, same as the one I showed before, the low quality, all that stuff, and then open it up to the world to design tools that will now be generalizable, both to high income, low income, middle income countries, as well as we want to be able to make sure that African colleagues can participate in the BRATS Challenge. So this hackathon is also to get them ready to be able to fully participate in this challenge. So I'm going to end here. I think if we were talking about bias in medical imaging, fairness in medical imaging, I think those are terms that people tend to use without any concrete ideas to how to solve those problems. I think one way to solve those problems is to think about the infrastructural challenges, the policy, the capacity. These have to be addressed across all settings, not just in the upper middle income class, not just in the weird populations, but across all settings. And this is how we can actually use the power of AI to enable everybody to have access to good quality healthcare. And I'm going to end here. So thank you so much for the invitation.
Oh, thank you so much. I loved it. I don't know where to start. There's a
as well. Thank you. Go ahead, please, Eugene. But it was amazing. Thank you both so much.
Yeah. Sorry, you said you have to go at 12, but are we able to have a bit of a discussion?
Yes. Please go ahead.
Okay, yeah, I love that the working together slides, especially in a platform like this, McMahon. We would love to have some of your colleagues and students from Africa next year, or even this year, if they want to join us, and working together in the future. And I see that there were a few parallel things that Marianne and you both mentioned. Marianne, your presentation, you mentioned the 2 key points: data input elimination and outcome evaluation, and for Udunna as well, where you mentioned the infrastructure and policy changes that it's part of the key points where we can start working together globally together. And I saw that there were some questions in the chats where this kind of protocol, data privacy, confidentiality, data protection, sort of governance thing are mentioned. So would both of you like to share some of your insights on how that's done at your institution or where you work and so on and so forth? I saw Marianne already have some have some answers over there as well, and Shireen, feel free to chime in as well.
Yes, can I just start to say I'm really humbled by Udunna's presentation, because I pointed at problems and she's actually proposing solutions. So I'm really impressed by the work you're doing. I think it's amazing. Yes, so questions of ethics and governance are primordial and really, really challenging. The way we handle it in our institution, like the setup, the infrastructural setup that I mentioned, it comes with a kind of umbrella ethics, so that we're all, vetted by the hospital to be able to do projects on this anonymized database. And then we put it project-specific applications to have access to the anonymized database. But because it's covered by already this umbrella ethics agreement, which we have with the government and with the hospital, we have a very quick turnaround on this ethics application. That's about 2 weeks. So we've done a lot of work against the work of Gareth. We've done a lot of work upstream, because we knew we were going to plan to use this infrastructure for research. But I think it's the one thing to remember, maybe for the people on the call, is that you need to make sure, yes, your ethics and your information governance are in place. Those things are complicated and they take time. Don't underestimate the time, and do approach. I think any kind of clinical institution now have people who are full-time dedicated to these issues. Talk to them as quickly as possible when you're thinking of designing a project.
Yeah, no, I echo what Marianne said. It's a bit difficult to do this when you're cutting across geographical areas. I mean, like just being able to get data between Canada and Europe becomes a problem when you have GDPR and all that stuff. And then when you're trying to work in a landscape where there's no policy as per se, then we're trying to create that policy. And we're trying to work with the ethics to understand how things are done in Africa. So that's kind of that having that ethical process and making sure you do it right it's a bit of a challenge. It takes time. We don't have 2 weeks. I wish we did. It's been almost 2 months trying to get the ethics for AFNIA up and running. But we are mindful of the fact that we're in new territory, if I should say that. So our ethics and our contracts team here, it's really good at trying to make sure that this is done and done right.
Thank you both. Yeah, sorry, Shireen, please go ahead.
No, I think it's that I also agree with everything that has been said, and usually it's much easier to get the permission to work with data and from your own institution. But as long as you are going to share with other institutions, even in the same city, you have to have data sharing agreements going on between the 2 hospitals. In different European countries come then additional barriers and time. So I think I have a study ongoing now with 5 or 4 different universities in Europe. It took us 1 year to get a data sharing agreement in place with all of the universities. So it is important to start in time when you have an international study ongoing.
And this is why, open access, open source data are so attractive, because they allow you to get started quickly, I guess. But like Udunna said, we need a wider representation of this open source data. And when you have no ethical framework available in some countries, just making their data open access can be a challenge.
But also meeting Udunna or speaking with her, we accidentally met in a lunch, helping faculty at McGill during COVID. And it opened my eyes, because when I'm thinking about fairness in AI, I always think about including other populations, ethnicities, and so on. I never even thought of infrastructure, because I have the infrastructure that I need here. So that was an eye-opening. And Udunna, since our first meeting, I actually thought of have to have a cheap PET scanner. So I have an amazing incoming student, and we have a solution. So we have to talk.
Yes,
so
for sure. We will.
The team be working together very much so in depth, have to help out, because it is very important to give access, cheap access.
Yeah, no, we have to talk about that. I mean, I was just at a meeting in London, Ontario, the London Imaging Discovery, which was focused on what they call frugal biomedical imaging. That bothers me a little bit, because I think we just have to be frank as to how we speak about this. If South Africa had rapid kits, that's cheap version of PCR, we would not know what Omicron is. So when we're talking about this cheap, frugal technologies, I don't think that that's the only approach we should think about. And there is a space and ecosystem for them. What is the cost benefit ratio of these cheap technologies? So I'll give an example. Hyperfine, and I don't want to call out the company, but they do have a really good brain MRI portable system. They've demonstrated its utility in stroke and in hydrocephalus. They have these systems across Africa now and India and some of these low-middle-income countries. But we don't know what the value of that system is for a place like Africa, where, like I said, the #1 clinical indication for MRI was brain. When you look at what those clinical indications said, they're for TBI and they're for stroke. However, the stroke validation that was done here on this system was done on an acute stroke setting. Most stroke settings in Africa are not acute. Patients show up days later, not weeks and hours later like we do have here. So the contrast of the MR images that you get here are not going to be the same, because stroke evolution changes the MRI contrast. That has not been validated there. So we don't know what the value of these cheap, frugal technologies are when you deploy them in a setting where they don't even have the technical expertise to use some of this system. I think it's time we get away from making products and dumping them in Africa or dumping them somewhere else, because that's what we're doing right now. Because of the lack of access and equipment, most clinics would be willing to accept those technologies from you and figure out, oh, okay, well, let's just figure out how it works. When I was in Nigeria, I went to 15 different clinics, and these include hospitals, private clinics, and in between. One of the national hospitals, I saw in the hallway, ultrasound equipments lined up. These were donated. They're not using them. It's useless to them. So frugal technology is not, I think, the all and end all. We just have to be careful how we're designing them and what the outcome is. I think if we give them the capacity to figure out what their problem is, they're capable of designing their own tools. They do have MRI systems right now. They do have Linac systems. They do have PET CTs. Let's just create that power of experience locally, and then they could train their own people, and then they could figure out their own problems. I'll stop there.
Yes, I think working together, and also I agree with you that the development should co-development and co-development of both software and hardware, and not just developing something from a company, invest and dumping. I totally agree. And that should be the solution, and access, and also not just for Africa and other low and mid-income countries being donator of images rather than co-developers and co-investigators in our studies. But then for us, for example, for Marianne and I and many others who would like to have co-investigators from these countries, we don't have the contact point, where to go. So I think it's very important also for us to have a networking, because I met Marianne at a conference organized by universities in West. We don't have, if we don't have this contact points, if we don't have this interaction and networking points, it's difficult. So I think it's time for us to organize this international PI meetings where we can meet at the same level, where we together, not just I am going to donate you something, I'm going to give you something, but can you come and be my co-PI and the study?
So that's a network we're trying to form. That's CAMRA. That's what we're trying to do through this Consortium for Advancement of MR Education and Research in Africa. We're trying to put together that network. So feel free to reach out. I could just quickly pop up and share that screen again. Sorry if you give me a second, so you can have the email contact. So that's exactly what we're trying to do. We're trying to really create that network where people can, on their own, just like you met Marianne, and it wasn't something that was spurred on by you, it's you guys just met one-on-one. We're trying to create that space where we could do that. There are several other efforts that I didn't have time to speak about. Just give me 1 second. I don't know if I have.
Yeah, and I met you on the event that McGill organized. So without this interaction points, we can't.
Right. So yeah, so I will encourage you to look at the website. There's a few things I didn't mention that's going on. You can pop up an email here. We are creating a database of some sorts. We're going to have this all worked out very soon. And where you can fill out your name, institution, your research interest, what you can provide, what tools that you have, if you have MR, if you have radiograph, if you have Linux, whatever, make a model, because that's really key and important. Once you have all that stuff in place, it will be something that will be open up to people to be able to complete, and then we can start to link people together. We are hoping to have some meetings in Africa sometime next in the year after. One I talked about was this hackathon. And this is where we can network with, for example, MedHack, linking together with the work we're doing in AFIA, trying to run a hackathon. We're linking in with data science, existing data science ecosystem in the continent, like Data Science Nigeria, ACE in Uganda, as well as India, but in Africa. So we're trying to create also that ecosystem and space where you also can come in and just sort of get linked in and plugged into this existing networks already in place.
That sounds great, Udunna. Also, I'm very interested. We have a medical physics campus accredited program. It would be good to put us in contact. We train medical physicists. With all my collaborators anywhere in the world, I send students, but also I receive students from those labs. I would like to do the same with my African colleagues. But again, this, I think, forum would be great for us to, in fact, and to make that interaction on the same level. We are PIs. Let's collaborate as I do with my European colleagues or my American colleagues, and so on. But unfortunately, until now, it has been very difficult to, at least for myself, to find that key space where I can interact. Yeah, so this was amazing. I don't know, Marianne, what you think about this. ESTRO, you're engaged in ESTRO. Could something be done in that context as well?
I can definitely propose it. Let's talk offline with Udunna as well and see how we can best bring some radiotherapy into this network.
Mm-hmm. Because we have an international network here at McGill, but it's just different professors giving lectures, and I don't actually I have intendedly not signed up for that because I think totally meaningless. It's me going lecturing, for people, and I don't want to do that.
At the University of Manchester, we're setting up a big research and education program jointly with Kenya, but it's very biology focused at the moment, so it could be interesting as well to see how we could bring some more physics and computer science, because the great thing about the work we do and all those computer models and those AI models, that they're actually relatively cheap compared to biology research, and they don't rely on getting some biological materials or some expensive sera or some things like that. We just need a reasonably powerful computer and a good internet connection, which is a very cheap investment actually for the benefits that you can get out of it. So I would be very happy to discuss this offline.
Mm-hmm. Well, thank you all very much. I think this is wonderful, the discussion that's being had here. I guess that not only applies to all of our PIs here, our participants as well. You guys are from a very diverse different countries, and feel free to connect with each other. And we have the meet and greet.
Bayode is here. Bayode, do you remember first time? I think you are from African country, if I don't misunderstand.
Yes, I'm from Nigeria.
Yeah, in the beginning, you told me that you were in radiotherapy, but you didn't know how to, if you want to change subject. As you see here, there is plenty for you to do in Africa in the field of radiotherapy.
That's right.
Yeah, and please reach out, because I'm happy to share resources and whatever you need to be able to do this in your country, to broaden expertise in your clinic or in your university. But it comes to expanding on your radiotherapy knowledge, because what I understood was that you were working in a wet lab setup.
Yes, I'm actually currently doing an MSc program in Creighton University in Omaha, US. Yeah, so I resumed some few months ago in the spring semester, and I was deciding on which research path to follow. And it was at that point I was trying to get clarification, at the earlier part of this program. Yeah, so basically, I think I've been following all the while. I think this has been helpful so far.
Yeah, and I do want to point something out, because I don't want the audience to think that we're just hyper-focused on Africa. The idea was to actually figure out if we can look at all the complex overlapping problems that the continent have, because they are indeed a unique continent that has all those overlapping problems. If we're able to solve those overlapping problems, we can easily adapt them and solve them anywhere else. If we focused on India and started to solve all the problems in India, we cannot adapt them to Africa. It just doesn't work that way because of the landscape, the big challenge that we have. So when you're thinking about some of the challenges that I talked about, or some of the solutions that we're thinking about, those solutions also can readily be adapted to other parts of the world, and also to other healthcare needs, not just imaging, because when it comes to data, the same infrastructural policy, personal capacity cuts across all medical healthcare systems. And that's why we're trying to take the systematic approach, where we can sort of start to use medical imaging as a model, use Africa as a model, try to create these solutions that we can then adapt to different healthcare issues and to adapt them to different geographical settings. And so I just don't want people to think that we're just kind of hyper-focused for no reason. There was a reason behind just trying to focus on that.
And Farhad, I see you unmuted as well. Is there anything you wanted to add as well? Or? Are you speaking? I can't hear you.
Can you hear me now?
Oh, yeah.
Okay, perfect. Good. So I have a question regarding, right now, one of the challenges as I go through hiring a new student for my lab, for example, is that we don't get that many applications. Our approach is really to keep EDI in the center of all of our research, but we don't get that many applications from Africa. And that's really a challenge, at least for other colleagues from computer science. Through initiative like MedTech, one thing that we really we're planning is to not focus on technology that make access to the content really limited. So even technical things, we use infrastructure that is publicly available all around the world, and to increase the chance to reach out to people from different countries. But still, we among different continents, Africa is the continent that we haven't been able to really reach out to many audience. What is your suggestion based on your experience, how we can increase the chance to interact with students? Because medical imaging is a really multidisciplinary approach, and it's really a chain. As you mentioned, sometimes having one IT person on ground will make a difference. So how we can, what policy or suggestion you have to reach out to more students from Africa, for example?
Well, I want to first say that I'm not the philosophy or the school of brain training. So having students come here and train. I mean, I did physically, not physically, but I did bring students here, paid out of pocket to get them here, because it's one thing for them to get visa. It's one thing for them to get stipends. They cannot afford to pay basic visa cost or basic cost of getting the x-rays done for their visa. They're just not going to come here. But also when they come here, if you're going to train them here, you have to realize that it's very hard for them to go back. So you're brain draining the system. So again, we have to be careful how we train and also who we train, because you can train them there and give them all the resources and train them there. But if they don't have this support system to use what you train them there for, they will leave. Most of the physicians that I met in 2020 have left Nigeria. There's a physician in Kenya that I know of that I'm working with. He's no longer in Kenya. He just left this year. So if we're training them, we have to be mindful how we train them and who we train. You cannot train everybody. It's just a waste of resources, not sustainable. So you have to be able to train champions, people that can stay. If they stay, you have to provide them a network externally, either through writing grants together, either through co-supervision of the students, which means you supervise the students, but you get 0 credit for it. So if you're ready to do that, then you can get working on the ground. So if we're able to figure out how to train, who to train, and make sure that the training stays in place, then you can start to make an impact. Just finding students, if you want students in your lab, in 5 minutes, I will give you a long list of names that are willing to leave the continent and come train in your lab. That will make 0 impact on the ground. That's not how we train, and that's not what I think is the best way to train. If you're thinking of doing MedHack and having them attend this 8-week meeting, this is great. I mean, Africans love certificates and stuff like that. They like to collect them and hang them up on their wall. So they have no problem attending this meeting. The question is, when they're done this, can they go back to the MRI scanners? Can they go back to the Linacs? Can they go back to their CT scanners and actually do something right now that can make a change? So again, when we're building these workshops and training, we got to think about sustainability and how that can make a change. So it's not just, if you want students, it's easy to get you students, but the question is, how do you then continue that? How do we do what NCDC, ACDC did in COVID, where they're able to get the experts? So one thing I forgot to mention, some of these experts were trained in Nigeria, trained in Kenya, left, came back and stayed and made a change. How are we going to be able to do that? They're only able to do that because, unlike what we're talking about, the federal government of these countries invested in them staying. When it comes to medical imaging, radiotherapy, all the stuff, there's no investment right now. So if you get these physicians, if you get this physicists, if you get these engineers trained, how are we going to sustain them to stay? If not, they will leave.
Thank you. That's really a great point. Yeah, I'll be glad to follow up later. Yeah, we definitely will be interested into solutions that are sustainable. And I understand the concern regarding students having the knowledge and not being able to use it. And at the end, it might not be really impactful. Thank you.
And Udunna, both Farhad and I come from a mid-income country as Iran. And brain drain from Iran is now, beyond, everybody in principle that we train, our country trains, they leave, which is not good for the people who stay behind. So if you look at McGill University, I don't know how many percentage of professors are Iranians, significant number of professors. So
it's only good for people that stay behind. It's just not good for anybody, because imagine if South Africa had nobody there to detect Omicron. We know Omicron is. So I think it's time for us to go beyond what we can do for them and just realize that we're all in this together, especially when it comes to global health. So also being able to have people that stay on ground and can see the disease across spectrums, how cancer manifests, how Alzheimer's manifests, how stroke manifests, is also in relation to the environment, the physical, the social, the cultural environment that the person is. So being able to actually have people that stay in place is not just a benefit to the local community, it's a benefit to all of us. Absolutely. If we have people that stay in place. And I think once we start to see ourselves in them, and once we start to see the benefit of having everybody have equal capacity, which is what we stressed out in the radiology AI editorial, is that we have to have this infrastructure policy capacity across all settings, not just let's just help out this white knight, let's save. No, it's just that we need to start thinking about it where we all benefit. If everybody has equal access, if all brains are online where they are, then we could make a bigger difference globally.
Yes, I agree. And what I'm telling you, with the pet challenge that you told me a while ago, I would like us to co-develop something with the university in Africa, but also in Iran and other countries, to develop something that they co-develop together and hopefully can use it. And also everything from constructing a device to image reconstruction and so on, so that even if this system in the end is not clinically used, it has still teach X number of students have to work with a variety of toolkits, and hopefully many innovations will come out of this. But I totally agree with you. For us, for example, right now, I pay for students of our medical physicists who do not have their own grant, and I have zero benefit from it. It becomes their student. However, I supervise and pay for the student. So I'm willing to do so for others, and we can talk about this offline. But for me, this is very, very important, as I totally understand you. I very much dislike initiatives where people can go and give a lecture at a random university in the low-income countries and think that they've done their part without giving. You cannot just take. And I don't want to just do such a thing, put it on my CV and move on, because I'm not interested in that. So I think this is a very nice initiative, and I hope that everybody in MedMacax here as well who is willing to can sign up, and because we have many professionals in our audience here as well who can help out, and many of them are living in the countries that we are discussing here, to contact us so that we can together get rid of some of these biases, hopefully with time, as equals.
Yes.
Yeah.
Thank you so much, Shireen and Udunna, and as well as Farhad's question. I learned a lot, and I'm so glad to have you here today, as well as Marianne, but I think she unfortunately had to go, so she didn't get to say goodbye. I really, really enjoyed this session. Thank you so much. I know you have a meeting very soon. So with that, I'd like to conclude the session today, and we'd love to talk to you more offline. Thank you. And we'll see you. Yeah, well, we'll see the rest of the participants tomorrow for a workshop on PyTorch model evaluation and training. Thank you very much.
Thank you so much all. Bye-bye.